Dr. Choll Kim here from sunny San Diego, California. I have with me Dr. Chris Rogers,
Hello.
a board-certified physical medicine and pain specialist, and he, a while ago, moved to Carlsbad to focus on taking care of patients with golf injuries, which makes a lot of sense because Carlsbad is essentially the home of golf. That's where the headquarters of Titleist, Callaway, TaylorMade, King Cobra, and probably a bunch of other smaller companies that support a big company like that, they're headquartered there. So he is a very smart guy, and we're really excited to talk to him. So let's just start out with the very first question. Why is golf so hard on your back?
Golf is challenging on your body. It requires a lot more fitness than you would think. Most of us weekend golfers aren't exercising our spine 5 days a week like the pro golfers are. On the flip side, most pro golfers are hitting thousands of balls, a day. And so even though they're fit, there's this high repetition that causes damage to the spine over time.
Would you say that the golf swing is kind of awkward, or is it kind of a normal swing? And don't say it's awkward for you, but normal for everybody else, because that's probably true too.
Well, I'll tell you what my golf instructor said. I said, I think my golf swing is, I think my back is messing up my golf swing. He said, no, your golf swing is messing up your back. And so as important as keeping your body fit, it's also good to get coached on the swing. It's not a natural position to bend over and, swing with all your might at a ball on the ground.
So depending on what kind of golfer you are, you're probably bending down to pick up a little white ball from the ground and standing straight up 50 times at least. If I did that right now, I probably wouldn't be able to get up in the morning. So from a spine surgeon standpoint, I would say that the problems related to golf, I think about anatomically. So in addition to the weird swing and the fact that we're really not in shape enough to play golf once a week, we need to be kind of conditioning. You can injure certain structures. So as a surgeon, I think of anatomic locations. I would say that the three most common locations are the disc,
for sure,
followed by the facet joints. And then this is not really an injury, but the muscle tendon complex is a big contributor to back pain related to golf. Would you agree with that? And would you add any other anatomic sites that you put high up on the
I completely
list?
agree. If you look at non-golfers, the most common cause of chronic low back pain is for sure disc degeneration. And that could be anything from a small tear in the disc to a full-on herniated disc or degenerated disc with instability of the segment. But you understand that the goal of the disc and the joints and the ligaments is to give you motion, but have stable motion. And then the muscles are a dynamic system that allows you to do the same. As soon as any of those structures are disrupted, people generate pain.
All right, so you said something really important there, but I want to get to it in a second. But let me ask you a more general question. Is there like a set of preventative exercises, maneuvers, anything that you can do, some kind of magical thing that the everyday golfer can utilize to kind of immediately decrease their pain and the risk of injury?
For sure. The most common mistake I see golfers our age, we won't say our age, but our age and over, is not stretching enough and not stretching daily.
No comment.
Yeah. And particularly stretching the hips. A lot of people think they need to stretch the low back. Most of the rotation in the swing comes from your mid-spine, your thoracic spine, and your hips. And so those are the areas you want to focus on with your stretching. The flip side is stabilization or strength, the ability to maintain a good, healthy posture that protects your spine. And so those are the core exercises that everybody talks about.
All right, so I want to dissect that out. So the first thing is, don't do what I do, which is show up 5 minutes before your tee time and hit your first ball totally cold.
Totally agree.
Warm up.
Yeah, hop out of bed, grab your heavy bag of clubs, throw it in the trunk, sit in the car, drive. That's another issue. Sitting for a lot of disc is a problem.
Yep.
And riding around a golf cart, bouncing around on that disc is a problem. And then, like you say, going right out and just hit off the first tee as hard as you can. You don't want to do that. You want to wake up in the morning, have your hot cup of coffee, do your stretching, do some toning exercises, go to the range, do some warm up, and then go out and have a good round.
No one does that.
Nobody does that. Well,
but let us all commit to ourselves that for all us golfers. Let's get there 30 minutes early.
Yeah.
Stretch out, warm up, etc. I didn't know about the hip stretching. So tell me a little bit more about that. Because I generally stretch out my back and my hamstrings, but I've noticed many of my patients, they have a lot of hip range of motion problems because I don't think people know how to stretch out their hips very easily.
We as a society do too much of what we're doing right now, which is sitting. When you're sitting, there's a tendency for the muscles in the front of the hip flexors to get shorter. When they get shorter, they pull your pelvis in a position that makes it difficult for you to stabilize your spine during the swing. So stretching out your hip flexors is key. Also, strengthening your hip rotators so that you have stability throughout the swing is important. And the good news is when you're stretching, your muscles are also getting stronger. And when you're strengthening, your muscles are also getting more flexible. So it's not one or the other.
So that's the second thing that you brought up. I'm a big believer in rehab.
Yes.
That's why we're such good buddies, because
Yes.
your job is probably more important than my job, because I can do a perfect surgery, but without the right rehab and the right kind of physical fitness afterwards, you don't get nearly as good of a result. So I tell patients the muscles that surround your spine should be not only strong, but coordinated. And the goal is to make them act like the world's greatest back brace. Does that make sense?
Totally agree. If you look at patients who have chronic low back pain, you look at how their muscles coordinate themselves, the order in which certain muscles fire. For example, if I pick up this cup, which muscle in my body is the first muscle to contract? You might think it's the muscles in my arm, but it's not. It's actually the deep muscles of your trunk. And why is that? If my trunk is not stable, it doesn't matter how strong my arm is, I'm going to tip over. So we find that patients who cannot activate their, to be technical, the transversus abdominis, the multifidus, the muscles deep in the trunk, if those muscles can't fire first, those are the patients that are those are people more likely to end up with back issues.
That makes a lot of sense, actually.
Yeah.
I have a lot of patients, when I ask them to fire their abdominals, they're like, I can't do it.
So
I can barely do it. Just try it right now. Everyone at home.
Yeah.
Tighten your stomach muscles right now. I bet you it'll take a second. Tighten your biceps. Split second. We know how to fire this really well. We are kind of confused about how to voluntarily fire our core muscles.
And there's two ways. There's two ways to fire these muscles. It's
Tell
different.
me more.
If I say, I'm going to punch you as hard as I can in your stomach, what are you going to do? You're going to
die myself.
quickly tighten up all the layers of your stomach, the external oblique, interoblique, transversus abdominis. If I say, I need you to hit a golf ball for 18 holes, you really need to have that inner core have endurance. So those muscles, those inner muscles have type 1 fibers. They're more built for endurance. The outer muscles are built for quick power, right? So when a golfer uses all the muscles during the swing, it's disadvantage to the spine because it compresses the spine more. It's going to compress the discs and the joints more. If you think about the orientation of the oblique fibers, they compress the spine. The deep layer, the transversus abdominis, those fibers run this way. They do not compress the spine. They just stabilize the spine. That's what core.
That's the difference between a surgeon and a rehab doctor. You understand they kind of like the physioanatomy much better. I'm much more like checkers. That looks bad, must be excised or surgically treated somehow.
Our patients need you too, of course.
Would you say that there's a group of exercises, kind of basic exercises that everyone can do to kind of get most of the way there? Or is this a problem where you really have to dive deep and get a customized exercise program for you to really make a difference in this area?
I think if you're a healthy person without back injury or back pain, general fitness will work if you incorporate some of these spine stabilization exercises into your workout. If you are a person who is nursing an injury, a herniated disc or arthritic joint, it's helpful to see a physical therapist or somebody who can really pinpoint what you should be focusing on, at least until that issue is resolved. So if your hips are tight, work on,
That's another way of saying it needs to be customized for that particular patient.
Correct.
That's what I find. All my patients say, just tell me what to do.
Yeah.
And I've tried giving them a set of exercises that it doesn't get you most of the way there.
Right.
And then I started telling people, this is going to be difficult. It has to be customized. You have to find a coach or a physical therapist.
You're exactly right.
And do a bunch of different things until you find the right set of exercises.
I tell my patients the same thing. I say,
good.
If I were trying to teach you golf, here, read this book. Doesn't work. You need a coach. Everybody has a different
That's a good way
area to
think
work
about
on.
it.
And you don't see it, but your body is different than everybody else's as well.
What would you say is the most common problem that you see in a golfer that presents to your office in the low back area?
Depends on the age of the person. So younger men tend to be more likely to have a tear in their disc.
I'll give you an example of the patient I'm thinking of. We have a 45-year-old.
Mm-hmm.
He is a dynamic, high-rolling professional. He's a lawyer or a doctor.
Mm-hmm.
Has a full-time job, very busy, travels intermittently, loves to play golf, and he's got this chronic low back pain that is nagging. He can work. At the end of the workday, he generally does not want to go to happy hour or anything like that. He still plays golf about once a week, but after every golf session, the next 5 days is just not fun. And they've tried PT and they've had X-rays and an MRI, and now they've come to see you. What do you typically tend to find in a patient in that kind of category?
Yeah, that person most commonly will have some injury to the disc, whether it's a herniated disc, a bulging disc, which technically is a herniated disc, a tear in the disc, some injury. And that disc, as you know, has 3 jobs. One is it stabilizes the segments. 2 is it allows some motion in that segment. And 3 is it protects the nerve elements. And so patients can present with any variety of symptoms. Their back can be in spasm. Their back could be stiff. They may have nerve symptoms. They may just have back pain.
And is it pretty common to have both a disc injury and a facet injury or a muscle tendon / ligament injury? And we should probably talk about the SI joint too, because that's down there as well.
Sacroiliac joint is important as well. It's less common of an injury, but we certainly see it, particularly in 2 groups of folks. One, the young female golfer who maybe had 1 or 2 babies, and now those ligaments got stretched and injured. Or the patient who has had not what you do, the minimally invasive surgery, but way too much surgery, multiple levels of fusion, and now there's extra load on the sacroiliac joint. Those are the 2 groups that we see getting sacroiliac joint issues. But the most common thing to your question is often disc. It can be combined with joint pain as well, facet joint pain.
So this is a conundrum that I get faced with a lot as a surgeon. So I have a patient that will come and see me. They have back pain, and they want to know why they have back pain and what to do about it. And the issue is trying to figure out where the pain's coming from, because it can be coming from the disc, the facet joint, the muscle, tendon, bone complex, and the ligaments, and sometimes the SI joint. How do you try to figure that out? What would you do to sort out where the main pain generator is in a patient like that?
So I've been treating the spine for a long time, just like you. I did a fellowship in 1997. And at that time, the dogma was there's a single pain generator. There was actually a paper published saying that patients either had disc pain, joint pain, or nerve pain, but not all 3. After 2.5+ decades of treating patients, I believe that's completely wrong. I think most patients have multiple sources of pain, and to complicate it, the sources of pain can change from week to week, day to day. So, for example, you may have a little crack in your disc. You sit too long on a plane or sit too long in a car, you get this ache in the back, kind of deep gnawing ache. That's disc pain. But then you sit a little bit longer, that disc starts to leak some inflammatory molecules. Now your nerves get a little irritated, you start getting pain down your legs. You decide to go up and pick something up off the ground. That disc is injured. It's not stabilizing that segment. Things shift. Now all your tendons and ligaments and muscles are screaming at you, and you're in spasm. So the source of pain varies depending on what the person's doing.
That's a really good point. So how would you try to figure out where the main pain generator is? Because as a surgeon, I have to find something to operate on. So I'm constantly asking myself, is it the facet joint? Is it the disc? Is it the muscle bone tendon complex? Is it the SI joint? What would you recommend somebody like me, like how would I go about trying to sort that out?
Well, you do what you do every day. You take a history like you just did. So you ask the patient what activities bother them and where do they feel it. Sometimes the location of the pain is not a great way of knowing where the pain. You've seen patients that have fractures all the way up in their thoracic spine. They have low back pain. They have a herniated disc. They have low back pain. So location of pain is not really great. But the activity that provokes the pain is a good clue. Then you do a great physical exam. You got to have them take all their clothes off, put on some shorts, have them bend, twist, do all things. If you have to get them in the gym, have them do certain movements, see what it is that their body can and cannot do. And that usually leads to a really well-designed, customized rehab program. And that's the first line of treatment for most of these patients. For the patients with more severe pathology, so large herniated disc, severe stenosis, they may not be able to do those kinds of things. They're the ones that are more likely to come see you.
Those patients are easy.
Yeah.
Because the diagnosis is straightforward. It's the patient with low back pain, with degenerative changes in their spine. And I'll give you an example. An annular tear seen on MRI, it's obvious.
Yes.
They have some musculoskeletal tenderness. So when you examine them, they're sore at these little focal points where the tendon inserts into the bone. Patients that have pain sometimes with this thing and sometimes not. So let's go over that. And the way I want to talk about that is let me grab a spine model. If you have a disc injury and you lean forward, it pressurizes the disc. So patients with disc injuries tend to have more pain with flexion, right?
Yes.
The facet joints are the little joints in the back of the spine. And patients with facet joint pain, when you lean back, it hurts more than when you lean forward if your main pain generator is the facet joint.
Yes.
And then if it's the muscle bone tendon complex, you can generate pain mostly by just pressing on specific areas. Unfortunately, it's not that clean. So I personally request my pain colleagues like you to do very targeted injections with not only the steroid, that's the treatment, that's what we're trying to get you better with, but at the same time, we're trying to figure out what's going on. So I beg my pain doctors to include an anesthetic in the epidural steroid injection. So both the anesthetic and the steroid. And for the first 4 hours, if the pain's coming from the location that you injected and the numbing medicine has blocked the pain signals, you should feel better. Here's the dilemma. I get a lot of resistance from pain doctors about adding an anesthetic in with the steroid. Usually they tell me the patient they'll be paralyzed for a few hours and they'll freak out. But I'm thinking to myself, well, that's not an irreversible problem. I can see how that would be distressing, but it's more important to get a good diagnosis. And by the way, it hardly ever happens like that. So what is the reason that there's such a resistance to include anesthetic and injectate?
I do not resist. You can give a very low dose of the anesthetic. So let's talk about 3 different things. So in the case of, we're looking for a patient who maybe we think has joint pain, right? And by the way, it's not just one joint in there. There's 14 joints all up in that 7 on each side, right? So we have a lot of bad guys that potentially playing a role in this. So, but we can anesthetize the joint by injecting local anesthetic into the joint.
We do that routinely.
Correct. Or we can block the little nerves that go to the joint. I call it turning off phone service. So we have 2 little nerves that will come to the joint. We call them medial branches. You can anesthetize the medial branch, and that will not paralyze the patient. That will just alleviate pain if their pain is truly coming from the joint. The problem is it's very hard for patients sometimes to discern if their pain has improved or not. Sometimes it's very obvious. I had this one patient, I injected her joint. She had back pain after a car accident for 35 years. I injected one little joint with local anesthetic. She got off the table and she started crying. I was worried that I'd hurt her. She was crying. She said, "It's the first time I haven't had pain in 35 years. So that diagnosed her source of pain. Typically, it's more subtle than that.
I have a really good example of the conundrum that I'm thinking of. It's not the facet joint, it's the disc. And you brought up a really good point. We have 5 discs in the lumbar spine. It would be like somebody with 5 knee joints in one leg showing up to your office saying, "Doctor, my right knee hurts." And you're looking at 5 knee joints in that right leg. And you need to figure out which one it is. So besides that, we have a disc with mild degenerative changes with an annular tear. Now, here's the rub. Most annular tears that are seen on MRI are asymptomatic, right?
Debatable. Depends. There was one study where, so there's this mean test you know about called discography, right?
Yes.
So you take an 8-inch needle, patient's lightly sedated in the OR. You take an 8-inch needle, you place it into the center of the disc, and you start injecting contrast. By the way, my group doesn't do this anymore, but it's still done commonly around.
I never order discograms anymore, but this is important.
So, but when you and I were at UCSD, this 20 years ago, we used to do this all the time. So we place a needle in the disc, and we gradually inject 1 drop at a time until the patient started to raise their hand and say, "Yeah, I think you found my source of pain." And at the same time, we're watching on video X-ray fluoroscopy to see if the dye is leaking out of the disc. So that's provocative discography. If you correlate that with the patient's MRI, 75 times out of 100, there is a correlation between the high intensity zone, the bright spot on the MRI in the disc.
I didn't realize the correlation
correlates pretty strongly, yeah. But the flip side is there are a lot of folks where you don't see that tear on the disc. The disc maybe looks dark, we say, it's degenerated, it's desiccated. But there's a tear in there. You just can't see it on the MRI. You see it on the discography. Now, the problem is there's some debate whether or not we're harming the disc by doing that procedure. So I really don't do that procedure anymore. If I'm going to inject anything into the disc, I'm actually, and this will maybe lead into our next topic, I will inject something that I think has the potential to regenerate the disc, which is platelets from the blood.
I love that. We're going to talk about that in a second. So let me ask you a very specific question.
Yeah.
You don't do provocative discography. So provocative discography is when you try to increase pain in the disc by like pressurizing it with a needle. Most contemporary spine surgeons don't order that anymore.
Right.
So I like doing a transforaminal epidural where the needle goes on the back of the disc where the annular tear is, and you bathe just that tear on the disc with an anesthetic and a steroid.
Yep.
And then I ask the patients to tell me whether or not they notice a difference in their symptoms before versus after the injection within the first few hours when the anesthetic is working. And if they say, oh, my pain got a lot better, I'm pretty confident that that has told me that that's a symptomatic annular tear. The patient says, oh, the pain was exactly the same, then I would say that that's an asymptomatic annular tear. Does that seem reasonable?
I think that the literature is still controversial on that topic. I think the tears, there's so many different types of tears, as you know. Some of them would be positively impacted by an epidural. And we say epidural, if I may. These little holes, you know this, but just for the readers at home, these little holes here are gives us access to the space around the nerves we call the epidural space. And that does allow us to put some local anesthetic on the nerve, which, like you said earlier, could make the leg a little sleepy for 30 minutes to an hour. Or it could anesthetize the back of the disc, but it probably does not anesthetize the disc. And there have been many different attempts made to try to anesthetize the disc. The thing we have to understand about the disc is the nervous system is extremely complex. Whereas the little joints have two little phone service lines coming to it, the disc has a spider web of nerves. It's a very complex network of nerves. So it's very difficult to numb a disc. It'd be great if we had a way to do that.
Yeah.
So it's really based on the MRI and the physical exam that we make the diagnosis of discogenic pain.
You're a little worried about the targeted injections for diagnosing discogenic pain.
I am.
From an annular. Okay.
Yeah.
Fair enough. I use that a lot.
Yes.
And here's an interesting thing that I found. This is not just related to annular tears, but almost all my surgeries. Turns out, before I do surgery, greater than 90 or 95% of the time, I recommend non-operative treatment, which before surgery, it's usually like a targeted epidural steroid injection with an anesthetic. So whenever I'm treating somebody, it almost always starts out with non-operative treatment. And as I'm going along, I'm getting more and more diagnostic tests. So when I operate on somebody, I usually have data like we did a targeted injection where we're about to operate on, and we know what their diagnostic injection response is. And the first cut, the success of surgery is like 85 to 95% if they have a positive diagnostic injection. And the patients that have a negative diagnostic injection, and we do surgery anyway, which I hate doing, but there's no other thing that could possibly explain their pain and they need to have something done, that success rate is only 40%. So you're right, the diagnostic injection isn't everything, but it gets me from 40 to 50% success rate. That's not enough. A 50-50 proposition for surgery, that's not enough for me. It needs to be at least 70%, but it goes from 40 to 80 to 90 to 95. So
very helpful tool.
Very helpful tool. That's one of the messages that I hopefully want to try to get across, but I want to get your feedback from experts like you. Let's now talk about like treating these problems. Let's talk about the annular tear. You have a bad disc, torn annulus, and for a variety of reasons, it's been painful. Just like we're talking that nagging low back pain patient that loves to play golf. What is your kind of sequence of treatment? What is your treatment kind of algorithm rationale for a patient like that?
Yeah, so after you do your physical exam and you look at the imaging and you have a sense of where you're going to go with this patient, if I think they're a good rehabilitation candidate, in other words, identify deficiencies in their mobility, deficiencies in their strength or their endurance, we're going to start there. And we're going to send them to a physical therapist that is going to spend time with them and target on those goals.
So you don't exactly care that it's coming from the disc or the facet joint. You're just trying to treat them functionally.
We're treating function. We're
that
treating
makes a lot of sense.
mobility and stability.
Just trying to get them better.
Correct. Because let's face it, how many people are walking around the United States with a bad-looking MRI of their spine?
A lot.
A lot, right? Especially as we get older. So I think it's above 50 years of age. It's like 80% of folks have some disc pathology on their MRI, and yet they are asymptomatic.
Right.
Whenever I give that lecture and show that slide, I say they're asymptomatic now. Doesn't mean they won't be symptomatic at some point in the future. So for example, if the patient who has an MRI that shows a little tear in the disc or some degeneration in the disc is feeling no pain, as soon as they take up golf, there's a higher probability that they will now feel pain if their muscular system can't support that injury.
They're more vulnerable to injury.
Correct.
You brought up a really interesting point. If you take like 160-year-olds off the street and offer them a free MRI just to see what it looks like, they don't really have any significant back pain. They would never go to a doctor.
Yeah.
They don't like have active treatment, but they just have typical nagging low back pain. A huge proportion of them will have degenerated disc, herniated disc, stenosis, and all kinds of abnormal findings. And I don't know if people understand that, but the MRI is just one of many tests. It's really sensitive.
Yes.
And I tell patients, you cannot just look at the MRI because there's so many terrible looking MRIs that are asymptomatic that just because you have a bad looking MRI doesn't require treatment. You need to figure out if that abnormality is a cause of symptoms. That's where the diagnostic injection comes in.
Yeah.
That's where all the history and detailed physical exam, which you probably do a lot better than me, comes in because it takes some detective work. So it's really important for people to know that just because you have an abnormal MRI doesn't mean you need surgery. I have patients come in and say, I have abnormal MRI, but they don't really have a lot of problems in their everyday life with pain or disabilities. So
I use the MRI as a non-surgeon. I use the MRI to find those patients that I think are going to do better with surgery and not waste their time with 3 months of physical therapy or injections that aren't going to help them. Massive herniated disc, severe stenosis, something like this, or God forbid a tumor, or some other lesion that we need to identify earlier. Mm-hmm. The second place I use it is to help me structure a rehab program that's not going to hurt them, right? So I'm not going to have them do activities that exacerbate an injury that I see on the MRI. I'm going to modify their exercise program with the therapist so that it protects the injury, right? So there's 2 ways I use the MRI. The MRI is a very useful tool, and fortunately it's less expensive than it's ever been to get one. But
if you're trying to make me feel a little dumb right now, it's totally working. That makes so much sense. That's like a higher level of interpretation of the MRI because I'm just looking to fix something. You're looking to
it's a roadmap
look at
for
the
you,
overall,
right? Yeah. So then the second point we should make is that we see plenty of patients who have severe debilitating back pain who have a very good looking MRI, right? A very good looking spine. I'm remembering a case of a young girl in her early 20s who had severe back pain, spasm, and her MRI looked beautiful. I mean, perfect. And when I examined her, I did a test. We don't do this all the time, but for certain cases, it's helpful to ask the patient to lie on the ground and then try to lift one leg over the other and then go the other way, rolling, we call it. And there's actually 8 different motion patterns that you can test. This gal was unable to do 8 of 8 motion patterns. So she didn't believe me that it was an issue. And so her mom and dad were there, and I said, okay, mom and dad, get on the ground. And they were able to do all 8 motion patterns without any problem. So we were able to emphasize that she had a
movement pattern for that.
I did. Got a 1-point Yelp review. So
I knew it.
But she was able to go to physical therapy and eventually restore those stability issues that she had. And of course, her back pain.
That's an example of pain due to a musculoskeletal problem.
Correct.
Not a disc, facet joint, or ligament.
Now, there may have been anatomical injuries that we can't see, right? Ligaments can get stretched out. You don't see that on MRI. There can be tears in your tendon. You don't see that on MRI.
All right, so let's go back to we have a patient with an annular tear.
Yes.
It's symptomatic. It's causing nagging low back pain. They're not debilitated. They're not in a wheelchair, but their quality of life is greatly affected. Don't ask me how I know this example. I just do, okay? What would you recommend as the kind of next treatment after you've tried rehab, physical therapy, exercises?
Right.
I'm a big believer in chiropractic care and acupuncture. It's a topic of another discussion, but now you're kind of getting closer to the point where you need to do something more invasive, like injections. What injections do you tend to choose for symptomatic annular tear?
If you see the annular tear and the person's symptoms are consistent with that being the source of the problem, we will usually offer the patient an injection into the disc using platelets from the patient's own blood. So this is something called PRP, platelet-rich plasma. This is where we draw about 4 tablespoons of blood, centrifuge it, you've heard about it. We concentrate the platelet fraction. Those platelets release what are called growth factors, cytokines, exosomes, a bunch of fancy names for molecules that are released by the platelet cell that have been shown to regenerate disc nucleus, regenerate disc annulus, the tissues in the disc. And when they're actually good study, I'll never forget the first time a doctor showed me the before and after MRI, because I was used to seeing MRIs always get worse every year, right? It's not typical that we see a patient come in the next year and their MRI looks better naturally. And this doctor was showing me the work that he was doing and showing that the disc was regenerating. In other words, brighter signal in the nucleus, the annular tear was gone, the high intensity zone was gone. So that was a light bulb moment for me about 10 years ago when I first saw that.
Yep.
Since then, there have been prospective randomized clinical trials showing that if you inject contrast in the disc or inject PRP, the patients who get high dose PRP, high platelet count PRP, do much better than the placebo group. I was starting to tell you about Dr. Ambach, my colleague, published this year a study where they looked.
My other favorite pain specialist.
Yes, we'll have her on the show someday, perhaps. And she and some colleagues performed a prospective randomized clinical trial where patients were randomized to receive either PRP in the disc or another orthobiologic, another biologic therapy where we take bone marrow tissue. So we stick a needle in the pelvis, we suck out some bone marrow, centrifuge it, concentrate the cells, and inject into the disc. And then a third group got a placebo. They had normal saline just injected in the muscle.
Let me clarify that. So the first group is PRP. That's the platelet lysate or platelet-rich plasma.
Correct.
The stuff inside the platelet cell.
Yes.
The second one you're talking about is kind of stem cell therapy. You take bone marrow cells, which have a lot of stem cells, and you give it back to the patient after you do a little bit of manipulation on it. And you inject that into the disc.
Right.
Because most people ask me about stem cells into the disc therapy. And what did that study show?
Well, it showed actually no difference between the PRP group and the bone marrow concentrate group, which was nice because it's more work and it's more discomfort for the patient to have the bone marrow procedure. Now, there are cases where bone marrow may be appropriate, but in this study, looking at these patients, they showed at 12-month follow-up, similar reduction in pain, similar improvement in function, and similar patient satisfaction. And the placebo group, of course, did not have those outcomes.
All right, that's really important because everyone asks me about stem cells. To get stem cells, they have to stick a big needle inside your iliac crest. I'm talking a big needle. And they suck out the marrow juice out of there and they spin it down. A platelet-rich plasma or platelet lysate is from like a blood draw, right?
Simple.
All right, so if I had to choose, I'd pick PRP if the results are equal. So that's new. That's really promising. And PRP has been well proven to be effective in many other areas of the body. So I really like PRP. The stem cell information hasn't been that robust. Is that fair to say?
Yeah, that's an entirely different lecture. Maybe we can just do a talk on stem cells. To be accurate, bone marrow concentrate, if a doctor sticks a needle in the pelvis and sucks out bone marrow, that is
correct stem cells.
It's not stem cell therapy. But what do I mean by that? If I suck out some bone marrow and centrifuge it, even when you do a very good job, there's different ways to do the procedure. When you do a very good job, on your best day, you're going to get about 50,000 of these, what you call stem cells or what we call mesenchymal stem cells. The most appropriate, the correct term is MSC terminology. Stem cell therapy is when you then take that sample to a lab and grow in culture. So now you don't have 50,000 cells, you have 50 million cells.
Because they've been cultured and basically amplified.
Expanded. Exactly.
I don't think that's that common anymore, is it?
there, it's not. It requires FDA approval.
So it's not common in the U.S. because it's not FDA approved.
Not permitted.
Only the bone marrow aspirate and kind of
Concentrate, we call it.
bone marrow concentrate.
Correct. You can centrifuge it. That's it.
What about epidural steroid injections? Don't you like those?
Yes, I do like them. And again, in my fellowship back in 1997, and then I met you shortly thereafter, I think I was doing 100 plus epidural steroid injections.
No one do the math, okay?
Yeah.
Moving on.
So I've done countless epidural steroid injections, and they're useful. They work quickly. Patients can get relief within a few days, provided that the pathology is not too severe, provided that the disc is not too badly damaged, provided that the nerve canals are not too narrowed. Patients can do very well. This is a bridge to then get them to the rehab, right? So the epidural calms down the nerve and then goes to rehab. The problem is, more often than not, it's a temporary effect.
Yep.
And so you hear about people getting a series of 3, or they may get epidurals once a year for many, many years. And this led me to look for a better option. And lo and behold, it turns out, again, to be platelet-rich plasma is the better option. So we have now at least 7 or 8 prospective randomized clinical trials comparing epidural steroid injection, so you inject steroid around the nerve, or inject a patient's own platelets from their blood around the nerve. Similar procedure, other than the fact of what you're injecting, and the results don't work as quickly, but they last much longer.
Would you say that you tend to do the epidural steroid injection first, and if that doesn't work, then do the biologic therapy, or do you now just jump to the biologic therapy directly?
Because insurance will not pay for PRP, but they will pay for the steroid injection, we usually try one epidural steroid injection first. It's just a quick way to get the nerve to calm down. If the patient doesn't get a satisfactory result and can't return to the physical therapy program, that's when we would consider the PRP.
That's exactly what I do. That makes sense. Just to clarify, the way I think about it is that a steroid injection is going to be really helpful for treating a condition that is causing pain due to chronic inflammation, not nerve compression, not stenosis, but something abnormal that's in this perpetual cycle of never-ending inflammation. And that happens all the time in other areas of the body. I'll give you an example. If you ever had tennis elbow, golfer's elbow, plantar fasciitis, rotator cuff tendonitis, those are all chronic inflammatory conditions. And you'll know that they're very painful and they last for months, if not years. And in that case, sometimes the body just needs a little bit of help getting to the point where you can just turn off the inflammatory process and keep moving down the path of the healing process.
Right.
If your pain is from something else, that's not going to work. That's why I really rely on the anesthetic, because if it doesn't work long term, I at least want to know that I'm at the right anatomic location so that if I operate on it, I'll know I'm at the right location.
But your description explains why PRP would be more effective in providing long-term relief versus a steroid. The steroid is going to, what does it do? It inhibits the immune system temporarily. That drug's in your body for probably less than a day, but it tones down the immune system. Why is the immune system activated? The immune system's activated because it sees tissue damage. You know, if you have a splinter in your hand, what happens? Your immune system runs to that site, you get a little red bump, and that's what inflammation is, right?
Yep.
If that splinter doesn't go away, if that tissue doesn't heal, the immune system continues in this chronic inflammatory state. This is what osteoarthritis is. This is what disc degeneration is. It's a chronic inflammatory state. You put in the steroid, it temporarily turns down the immune system, but then what happens? That tissue damage is still there. It just comes right back and reinitiates the pain process. PRP is not only platelet-rich plasma, is not only anti-inflammatory, not only does it release molecules that calm down the immune system, also releases molecules that stimulate tissue healing.
That makes
nerve healing, disc healing, joint healing.
Yep, it's much more regenerative and more biologic.
Yes.
I'm going to put you on the spot, and I do this all the time. You're this patient that I'm talking about.
I am.
With the symptomatic annular tear.
Yeah.
And you've tried exercises, PT, rehab, acupuncture, chiropractic care.
Yeah.
Now you're ready for an injection. Are you going to have a PRP injection or an epidural steroid injection for yourself?
With pain shooting down the leg.
Nope.
Just back
nagging
pain.
low back pain due to an annular tear.
Put PRP in my spine. I've actually had PRP in my spine, so that's a whole nother topic.
Okay, so I really like making medical decisions as follows. I mean, assuming that you know all the information and your decisions are based on, knowledge of your field, there's two ways to decide. Is this treatment that I'm about to recommend reasonable based on literature versus what would I do if this was me and my family member?
Yes.
Those are slightly subtle differences, but I'll give you an example of when that comes into play. I take care of a lot of physicians, almost no physician wants surgery. It's amazing how resistant to surgery they are and I take care of a lot of surgeons. If you're a surgeon, you're kind of like, that seems reasonable, but if it's for yourself, you're like, whoa, I'm not going to have surgery on myself. So I very much rely on that answer, not what is reasonable, but what would I do if it was my family member or myself, because that's kind of like the most credible advice you can get. So you're saying that you would go to a PRP injection before an epidural steroid injection.
I would. You're talking about evidence-based medicine. Evidence-based medicine. Well, evidence-based medicine is the published literature,
right,
your experience as an experienced physician, and the patient's goals and priorities, right? So it may not be the patient's priority to have a needle in their spine or to have surgery. We know plenty of patients like this, and they manage their pain level, even though we might do something different for ourselves. So we have to consider the patient's goals and priorities as well.
Good point.
So that's evidence-based medicine. I just wanted to make that point. But for this patient, end day of the week, just put it. And by the way, don't just put PRP in my disc. Put it in my joints, in my ligaments, and then put, there's evidence, there's one paper, but there is evidence that if you take the plasma component, not the platelet component, so when you spin the blood, the red cells go to the bottom because they're heavy. They got iron, so they sink to the bottom. The platelets are the middle level, and there's some white cells in there as well. And then the top level, no cells, just yellow fluid called plasma. But there's good stuff. Whatever you had for breakfast is floating around in there. Some other things, hormones, proteins, etc. That substance has been shown to regenerate muscle. So you know this. A lot of patients with chronic low back pain have muscle atrophy in their spine. They may even have fatty replacement of the muscle in their spine. There are studies that show if you take that plasma and stick it in the muscle, the atrophied muscle, you can regenerate the muscle. So I want to regenerate my disc, my joints, my ligaments, and my muscles in my spine.
Do you have a program that does that?
It's customized to the patient. So you look at the MRI, you look at the patient, and you figure out, okay, these are the top 3-4 things that are really causing your trouble, and you target them.
If you asked me a year ago the same question for myself, I would have said epidural steroid injections.
Yeah.
But today, it's not even close. I would start out with a PRP type injection, a biologic injection. So let's talk about a topic near and dear to my heart, surgery. So we have a patient that has, let's just talk about the annular tear, because that is so common now in my practice. So you have a 45, 50-year-old actively working, avid golfer with nagging low back pain. They've had all kinds of non-operative treatment. They've tried PRP and a variety of injections, and they're better, but still not to where they want to get to. And they come to see me. Most of the time, they come to see me way earlier, and now I'm kind of directing all this non-operative treatment because I spend most of my time, spend more time doing non-operative treatment than surgery. But, I really live for that patient that has been kind of filtered down to the patient that needs me, that has tried everything and they're miserable, and we know where the problem is. So when I see a patient like that, I have a few different surgeries, but here's the rub. A patient with a symptomatic annular tear, they're considered discogenic low back pain patients, and I would say that the standard treatment for that patient is either a lumbar fusion or a lumbar disc replacement. Those are massive operations. So for a long time, patients that have discogenic low back pain, I didn't have any surgical treatment for them. I would just tell them, just do the best you can, and really kind of thoughtful neglect, as they say.
Right.
But there's new treatments coming out on the horizon, especially minimal invasive techniques, in particular endoscopic techniques, where if I can identify a legit symptomatic annular tear, I can do a Band-Aid surgery and they get a lot better. Here's the problem. No surgery is 100% successful. And to me, I can never give up on this possibility that I can do every surgery successfully. So I would say that A really good spine surgeon has about like an 80 to 85% success rate. The majority of patients are better and they're really happy with the result. And the rest are kind of like not much better. And then there's a small portion that are worse because that's surgery, there's risk. So let's say 15% of patients that aren't doing as well as I would like. What can we do about those patients? Because I really mainly focus on PT and exercise, but the patients that aren't doing well, they have a hard time with that because it's painful. Right. And I know you're working on a new solution to this problem. Tell me more about that.
We are, and now you're talking about a very small subset of the total back pain population, right? So the patient has already gone through all these treatments. And before I get to what I do, I want to highlight that what you're doing with minimally invasive surgery is key. And I can speak as a non-surgeon, and I do this with my patients all the time. How important is it to protect the muscles, for example, right? You think about how fusion was done in the past and how using the endoscopic approach saves those muscles. Earlier, I talked about how important it was to have the multifidus muscle be healthy, and not just for that segment, but for all the segments above and below.
Right? I remember when you taught me that.
That was a long time ago.
Yeah.
So I think the approach makes a lot of sense. If the patient does not respond to any treatment, whether it's surgery or non-surgical injection techniques, you have to scratch your head and say, what are we missing, right? And so it goes back to the physical exam. You say, okay, how are all the segments above functioning? How are the hips functioning, et cetera? If it's in the spine, if you're still saying, okay, this is a spine issue, it's possible that there's a hidden tear in a disc above or below. Yep. It's possible that they have joint pain above or below. Rarely patients will get a little irritation of the muscle along the hardware, but that's pretty rare. But we target the area that we think is the source of the pain. And one of the things I love the most about regenerative medicine and using orthobiologics, using PRP and other cell-based therapies, is you can be artistic with it. You kind of like with your surgery, you can use your skill set to apply it to that specific patient's needs. So for example, if I have a patient who had a very successful L4-5 fusion, meaning that they're solid, but they still have pain, you now have maybe identified a tear above, but also I think they may have some joint pain below. In the old days, we had to choose. We're going to put steroid here or we're going to put steroid there. We can't do both. With cell therapy, I can put cells in the disc, and I can also put cells down below the other segments, along with the muscles, as I talked about earlier.
I love that.
It's
what about at the level that I operated on? What can I do to, turbocharge the healing and, results of surgery at a very specific level? This is something that we can do there.
So you're talking immediately after surgery. Some patients will
at some point after surgery.
Right. Within, say, a month to 2 months after surgery. Yeah. Some of those patients, as you know, will have sort of a lingering radiculitis, we'll call it. It's not a true radiculopathy. The nerve is not damaged, but it's irritated. It's inflamed, which is natural. It just went through a trauma. And that's where PRP can be helpful. There are different ways to formulate the PRP. I won't get into technicalities, but for example, you can take the platelets and freeze them so they break and they release all the goodies inside, all the proteins and growth factors, and that can be injected, just like we talked about earlier.
Is that platelet lysate?
Platelet lysate, yes. And so with platelet lysate, we've shown quicker relief of pain when it's injected in the epidural space. So that can be helpful after surgery. Commonly, these patients don't just have a disc degeneration that needs to be fused, but there's also some ligament injuries or tendon injuries that can be treated with PRP. So we like to say that surgery solves the anatomy problem, right? So the disc was too far gone, the canal was too narrow, whatever. The surgery fixes that anatomy, but now we got to fix the biology, the chronic inflammation, or the smaller tissues that haven't fully regenerated yet. And that's where biologic therapy can be useful.
Tell me more about your bioboost program.
Yeah, our bioboost program is something that we developed at our office where we can treat patients who had surgery and maybe have some continuing pain, so we can get them to get out of pain more quickly after surgery. In addition, we believe that we can provide more complete healing. So patients going to heal naturally after surgery. The muscles will heal, the tendons will heal, but some of them will heal incompletely. It's the same reason your golfer has chronic tennis elbow pain. The tendon can heal a little bit, but maybe it didn't heal completely. PRP can help finish the job. It jumpstarts the healing process. So by injecting PRP in the ligaments and tendons and joints, frankly, of the spine, we can get more complete healing as well.
I love that, to the point where I just want to do it on everybody and just maximize everybody's chances of really great results. So when is the best time to implement that strategy after surgery?
Well, I think we would take it on a case-by-case basis with you, because each patient is different, of course. But as soon as you feel like the patient has resolved as much of the inflammation and healing that they can do just naturally, if they're not following the typical trajectory that all your other patients are following, that's when we might introduce the bioboost. Now, to your point, it may be helpful to just do that for everybody, because let's face it, they all have significant multiple injuries that might need to be addressed.
So for me, that would be about 4 to 6 weeks. I kind of know that they've recovered from the surgery, and that's like 5% of the time I have patients that have some little problem that lingers for a few weeks, but it usually resolves in 4 to 6 weeks. So at that time, if they've not resolved, that would be a good time. That would be much more targeted to have like a bioboost, biologic, post-surgical therapy.
Yeah, I would agree with that.
I love that.
So we have patients who maybe aren't responding as well as we thought they might to a non-surgical approach. So we'll often refer them to you for consultation. How do you make the decision whether or not they might be a great candidate or a good candidate for what you do?
The decision for surgery is one of the most challenging things that I do, and you're right, it has to be customized. But generally speaking, my favorite patients are ones that have a specific known pain generator, so we know exactly where their pain's coming from. 2, that anatomic location is amenable to a reasonable surgery. So if you have to do some massive operation, I generally don't recommend it. And 3, the patient has to have a significant effect on your function and quality of life. So people always talk about pain. Here's the weird thing about pain. People will kind of modulate their function until they reach their pain threshold. So a person that has a lot of pain but has a lot of demands is more of an annoyance. It doesn't really affect their work, their social life. It's just kind of like me, like I'm a little miserable right now sitting here talking to you because my back hurts, but it's not affecting my function and quality of life. Even though the MRI looks terrible, I would not recommend surgery for that. I need to know that if the surgery is successful, how'd your function change? Like, I can now play golf without pain. I can enjoy golf. I can go and hang out with my work buddies after work when they go to happy hour instead of going home to rest my back. That's enough. It doesn't have to be like I'm in a wheelchair. In fact, waiting until you're so bad that you're in a wheelchair is one of the worst things that you can do, because by that point, it's really difficult to get you back to a high level of function. So it has to be customized. And I very much tend to, if it's a 50-50 call, choose the slightly lesser version of the surgery that is in terms of invasiveness. So as a minimally invasive surgeon, I'm always trying to do slightly less than too much. Both of them are bad, but I just tend to be slightly on the less side if it's a 50-50 call. And that's why I tend to do very few fusions now, because fusions are a very reliable way to treat discogenic low back pain if you have the right diagnosis. But it's such a big surgery that the risk is high. It's sort of like if I drove 90 miles an hour on the freeway at home and I didn't get into an accident, I'd get home really fast and I'd be like, I got home so fast. But if you have trouble at 90 miles an hour, it's a whole different world than if you get into trouble at 60 miles an hour. So there's this kind of balancing act of the risks versus the benefits. And so I'm a big believer in having a very accurate diagnosis before you do surgery, because it doesn't matter what surgery you do. It has to be at the right location. And then once you have an accurate diagnosis, picking the least worst surgical treatment option. Yeah. And that's where I come in. And I ask myself, what would I do if I was me? Because if I don't ask it like that, I get very confused, because I love doing fusion surgery. I love it. It's way more fun, and I have awesome x-rays that I can show people.
And you have great outcomes.
And I have great outcomes, but it's a higher risk operation. And when you have a complication going 90 miles an hour, it's a big deal. So, so far that's been very effective for me.
I think that's a great approach that you take, where you're weighing the risk and benefit for a given individual. Too common, unfortunately, in the United States, Are we less judicious in deciding to move forward with spine surgery? And oftentimes the results are not as good. So your clinical judgment is so important in addition to your skill as a surgeon. You know this. So now I have the question for our golfer patient. One of the common questions they will ask is, how soon after an injection in a disc or in a joint or even an epidural can I go back to play golf? And the answer is typically not based on time, but rather on which milestones have they achieved. So can they bend over? Can they twist? Do they have good spine endurance when we test them in the gym? Once they achieve those goals, then we can start releasing them to maybe play 9 holes and then eventually progress up to full 18 holes without introducing a risk of re-injury. Because let's face it, the patient's invested a lot of time, energy, and money in this treatment. They don't want to reset the clock and have to start all over again. So for your patients, after they undergo, say, a discectomy or spine fusion, how do you advise your golfer?
I get the exact same question, and it turns out I give a very similar answer. It's different for everybody. So it's customized. It's not a time thing, but everyone wants a time.
Yes.
But here's what's funny. Let's say I do the same surgery for the same problem on 2 different patients. One patient may be playing golf in 3 weeks. Another one won't be able to play golf for 3 months. So on the one hand, I just want to have a rule, 6 weeks. But that means that there's a group of patients that can go back to golf in 2 or 3 weeks that's going to be forced to wait for 6 weeks. By the way, my mom was forced to wait exactly 12 months before she could hit a ball. And I'm thinking, why can't she play right now? But we're so stuck on the time. She's a very fast healer. So just like you, it's all about function and pain, and we try to customize it. But you're right, it's usually about 6 weeks if I had to pick a number. But there's a group of patients that recover much faster.
Right. I think that's great. So we have patients who will not respond to non-surgical care, and we're often referring them to you for consideration of fusion. When do you decide to fuse or not?
Generally speaking, a fusion is a stabilization procedure, right? It prevents motion between 2 bones, right? It should be to treat instability or deformity. And so that's basically what I treat. The 2 most common things are spondylolisthesis, where there's slippage of one bone on the other,
right,
or degenerative scoliosis, where the spine's crooked and it's slipping sideways and it causes stenosis. In those settings, if you just do a decompression without doing a fusion, guess what happens? The spondy gets worse and the scoliosis gets worse. So that's why we do the fusion. We do fusions for a lot more reasons than that in general, including kind of arthritis pain. So imagine a patient that has a bad disc. We've tried doing non-fusion surgery on that disc, and they still aren't better. They may need a fusion to basically stop the bones from grinding back and forth. But that turns out that is very uncommon now. So I see a lot of patients that come to see me for second opinions. They've been told they need a fusion because even today, most discogenic back pain problems, the most common treatment is a fusion. So that's just statistically, that's going to be the most common recommendation. And I usually beg people not to have a fusion unless you have instability or stenosis, or you've tried other things and it's failed. Because if you do a fusion, you can't go back. Whereas if you do like a minimally invasive discectomy, if it doesn't work, you can still have a fusion. Kind of sucks to do 2 surgeries, but I know what I would do if I was me. If it was me, right, I would not jump to a fusion because I know what that surgery is like. Having said that, in the appropriate setting, when you need a fusion, you should have a really good fusion. And turns out those are some of my happiest patients. My mom, who is 87 now, had surgery when she was 84. She had a 2-level fusion. And I'm playing golf with her this Sunday. She's going to be 88 in April.
Is she going to give you some strokes?
She's going to give me some strokes. I mean, she's playing legit golf. And if she didn't have a fusion, she would be like a little old lady hanging out at home. But she's not. She's like very active. So a good fusion is a great operation in the right setting. It's just the risk of the operation that has to be offset. Here's one other thing that I should point out. There's now kind of 2 ways to do a fusion. There's the traditional open surgery. Right. I would say that almost 90% of all surgeons in this country do traditional open surgery. 10% of us do it minimally invasively. When you do it minimally invasively, you're still doing all the same things. You're realigning the spine. You're preventing it from moving. You're putting in cages and screws and rods and things like that. But you do it in a manner where you don't injure all the muscles that we think are really important. So as a spine surgeon, we're like, we don't care about the muscles, we don't care about the bone. We just want to fuse the spine and make sure the nerves are okay. But the muscles are really important. And if you're going to do a fusion, I strongly encourage people to find a good minimally invasive fusion surgeon that can do a good minimally invasive fusion. If you can't, find a good open fusion surgeon, because a good open surgery is still better than a poor minimally invasive surgery. But the optimum would be to find an excellent minimally invasive surgeon, because doing a minimally invasive fusion compared to an open fusion in most patients, it's like night and day. It's not a small difference. Right. It is a massive difference.
And those patients, as you know, the muscles span multiple segments. So the muscle's not just protecting the segment that you're fusing. It's also protecting the segments above and below, which is why in the more traditional open multi-level fusion, we see a lot of adjacent segment changes because they've lost the protective structures. They've lost the muscular support.
That's one of the drawbacks of a fusion as well.
Yeah.
Even a good fusion long-term has the risk of developing what we call adjacent level degeneration, and patients are very familiar with that problem. Right. And it's simple. There's two things going on. There's the mechanics, right? You've taken something that moves a little bit and made it rigid, so now the discs above and below are under more stress. Now, when you do traditional open surgery, and let's say you do a 4-5 fusion, when you do the incision, you disrupt all the muscles from L3 down to S1, above and below. You just can't help it, just the way it's all organized. When you do it minimally invasively, you specifically try to avoid injuring the muscle at the level above and below. So it's not just less blood loss, smaller incision, shorter hospital stay, less pain, faster recovery, although that should be enough. But it's very likely that the risk of adjacent level degeneration is much lower for minimally invasive surgery than open surgery. So I don't want to toot my own horn, but there's a lot of benefits. And at some point, everyone will do it minimally invasively. It's just takes a very long time for medicine to go through that whole transition process. And it's really difficult for, like most surgeons, to go through yet another learning curve once they're already done with their training. We don't want to train anymore. We just want to do the surgery that we've perfected over many years and just keep doing it perfectly. And I get that.
So we understand that protecting the muscles during surgery is critical. How do you actually do that with minimally invasive approach?
It's a combination of geometry, like the path to get to the surgical target site, and the way you create the surgical corridor. So I'll give you an example. Traditional open posterior, surgery in the back,
right,
is a long incision down the middle, and you take all the muscles and you separate them out by like this far so that you can work at your surgical target site, right?
Yes.
When you stretch that muscle out, you detach it from all its tendon attachments, and then you crush the muscle with these powerful, powerful retractors. And crushing a muscle is not good for a muscle. So instead of making one incision down the middle and stretching everything out, you make two incisions so that it's twice as much work, but the surgical corridor is smaller and there's less displacement of tissue from its normal position. So simply put, you're not crushing the muscle as much, and you're not detaching the muscle from the tendon attachments of the bone in the middle. Just those two simple things, making two separate incisions instead of one big midline incision, is probably 90% of the difference between open and minimally invasive fusion surgery. There's a few nuances on top of that, but it's just that simple. It's just a different, what I call, approach trajectory.
Science needs to move forward, right? And that's why what you're doing with a new approach that has better outcomes, probably quicker recovery as well, less complications. What we're doing with regenerative medicine to regenerate tissues that previously were not able to be regenerated, combining that again with good quality rehabilitation is the best we currently have to offer. Who knows what the future will hold, as we move forward.
Well, I think even right now, the field of spine surgery is really exciting. We have really good minimally invasive technologies. Now we have lots of advanced biologic technologies. Right. And I'm really optimistic about the future of taking care of patients with spine problems. So
I am too.
I'm really thankful that you were able to come today and talk.
It was my pleasure to come talk with you. And I'm also enthusiastic about the future. I think we know more about the spine than we ever did when you and I were back in medical school residency, and the understanding has evolved so much regarding the healing, and the new technology that you bring is really exciting so that we can improve the outcomes in our patients.
Agreed. Knowledge is power.
Bye.